international speaker, Dr. Richard Quinton. He is a consultant endocrinologist in Newcastle Hospital since 1999, and also an honorary reader in reproductive endocrinology at Imperial College London. Graduating from the Cambridge University in 1988, he trained in internal medicine at St. Barlow Hospital, London, and Erasmus University Hospital, Rotterdam, followed by the higher training in endocrinology at UCL Hospital, London. He has been active in research for greater than 30 years with the focus on male and female hypogonadism, female reproductive endocrinology, and a key interest in the congenital hypogonadotrophic hypogonadism, and has greater than 200 publications to his name. In 2000, he was awarded as a RAF Nobel Prize by the University of Cambridge, and in 2023, the Outstanding Clinical Practitioner Award by the Society of Endocrinology. He co-leads Society for Endocrinology groups on male and female hypogonadism and the EU COST consortium regarding consortium on the biology of the GnRH deficiency, and the NIHR funded test on consortium on the safety and efficacy of the testosterone treatment in men. We have also two facilitators. One is Dr. Faisal Masood Qureshi. He is the organizer of the PES Endocrine, Pakistani Endocrine Society for this workshop, and also Dr. Sarwar Malik. He is also a consultant endocrinologist. So I want to invite Dr. Richard Quinton for the presentation and proceed further. Give a big clap for the sir.
So many thanks, and I'm going to lower the microphone because I'm short. Many thanks. It's a pleasure to be back in Pakistan. 8 years ago was the last time. At the time, both myself and some of my colleagues still had darker hair. So I've got a lot of slides, but to be honest, I'm very happy to be interrupted, asked at any point, and we have a discussion. And if we don't get through all the slides, and in fact, if we don't get through any of the slides, that's fine by me. So please, if you have any questions, just jump up and ask me. So these are the potential areas that we could be covering. So the clinical features and how the Society for Endocrinology defines male hypogonadism. And I think the definition is important because Professor Brad Annavalt in Seattle, Washington State, USA, he says male hypogonadism is at the same time underdiagnosed, overdiagnosed, and misdiagnosed, and that many men who would benefit from testosterone treatment potentially are not getting it, and many men for whom testosterone benefits are rather dubious are being prescribed it or asking to be prescribed it. We'll talk about the classification and presentations of male hypogonadism. It's not always sexual dysfunction. The biological action of testosterone, how and when to measure testosterone levels, the regulation of testosterone secretion according to your internal environment and the external environment. The tricky thing of differentiating central, secondary, or hypogonadotrophic hypogonadism from what's basically non-gonadal illness. A bit about sex hormone binding globulin, insulin resistance, and the free testosterone hypothesis. Common pitfalls in the diagnosis, how to spot these. We'll talk about male aging and metabolic syndrome and the connection between these, bone density, anemia, and abusive versus safe prescribing of androgens. So the clinical features, I find it convenient to divide them into reproductive, non-reproductive, and so the reproductive ones we're quite familiar with. So these are the loss of or the failure to fully develop in the first place secondary sexual characteristics, sexual dysfunction, specifically low libido and erectile dysfunction, which comprises loss of spontaneous or morning erections and also reduced quality erections. But also things that are often forgotten about in other guidelines apart from SFE, subfertility and gynecomastia. So subfertility and gynecomastia. So the non-reproductive ones comprise physical and psychological. So your physical ones are fatigue, reduced strength and endurance, vasomotor symptoms, anemia, osteoporosis or fracture. Psychological ones are things like loss of motivation or concentration, irritability, low or labile mood, body shame, and psychosexual issues. And it has to be said that for the psychological ones, that's where there's the least evidence of benefit from testosterone treatment. So, the definition is it's a clinical syndrome comprising clinical features and laboratory evidence of impaired testosterone secretion with subfertility. Now, we're not saying that everyone should have a sperm count as part of the diagnostic workup. What we are saying is that if someone has evidence of preserved fertility, in terms of you have a sperm count and it's normal, or they've recently conceived a biological child, then it's exceptionally unlikely that they were hypogonadal in the first place. And then it needs further characterization as either testicular, primary, or secondary, central, hypogonadotrophic, whatever you want to cause it. Now, for primary hypogonadism, you've got a low testosterone and a high LH. You can diagnose that just with one blood sample, assuming that there's been no sample identification error, and without the need for clinical correlation. And the diagnosis is completely obvious. It can't be anything else. And if the patient's got no symptoms, doesn't matter. They still have hypogonadism. But it's trickier with secondary central hypogonadotrophy, because this requires repeat labs performed under standard conditions, fasted, early morning, and with sufficient contextual clinical ascertainment to be able to frame the diagnosis in relation to a recognized cause. So, for instance, due to opiate use, due to previous pituitary surgery, due to a congenital syndrome. If you have preserved fertility or a high normal hematocrit, because testosterone drives hematopoiesis, either of those two makes male hypogonadism extremely unlikely. And although the diagnosis conventionally requires 3 or more sexual symptoms, testosterone is equally important for general health and bone health as it is for sexual and reproductive health. And just say the Society of Endocrinology guidelines, they're not free to download, but they are free to read in clinical endocrinology. So classification, so primary is just like the light bulb is broken. Secondary, the light switch is turned off. And some actually use that to demonstrate to patients, literally plunges into darkness and nothing wrong with the light bulb, just the light switch is turned off. In the first case, the diagnosis is unequivocal. The second is trickier because your biochemical profile of central hypogonadism is indistinguishable from non-gonadal illness or sampling artifact from an afternoon or non-fasted venipuncture. So this is where you need the clinical correlation. And so differential diagnosis comprises structural causes. Interesting, traumatic military blast injury is much more likely to cause hyperpituitarism than kind of a civilian falling downstairs. Iron overload is always worth considering a simple ferritin test. Your genetic or congenital causes, your functional or reversible causes, which comprise constitutional or self-limiting fetal delay, systemic illness, and then if you're outside the Goldilocks zone, so if you're too skinny or too fat. Now it's interestingly that the male axis is a lot more resistant than the female axis to low fat mass, low BMI, but has a vulnerability to obesity, which the female axis doesn't really have. Corticosteroids, any drugs that raise prolactin can shut the axis down. Opiates, androgens, anabolics can shut the axis down. But of course, remember there's the misdiagnosis, so it's a non-fasted or afternoon venipuncture. You may have someone who has a very low SHBG level, so total testosterone appears low. There may be covert use of anabolics. In the UK, you can pick up androgens at any gym within minutes of entering, buy them off the internet. And it's interesting how there's a combination of where patients got a high body mass index, they've got a high hematocrit, they've got a low HDL cholesterol, and a low SHBG level. And you don't know what the problem is until they walk through the door, because that profile encompasses very different looking men about to walk through the door. So high hemoglobin, hematocrit, high BMI, low HDL cholesterol, low SHBG. Because you could see either of these guys. Anabolics, particularly lower your HDL-C, SHBG, and as does some obesity metabolic syndrome. And these are the kind of men who, particularly if they want fertility, the last thing they need is for you to give them testosterone. Now, I said that hypogonadism, we traditionally think about it as being the middle-aged or older man with sexual dysfunction, but actually, there are various presentations according to our journey through life. This graph, the white line charts the activation of the male reproductive axis throughout life, starting even in utero, before birth. And so in the fetus, things kick off around about 7 weeks gestation, when the indifferent gonad turns into a testis, and you get testosterone secretion or action. And without that, you'll be born with DSD, or potentially even externally female. And then your next phase is the fetal gonadotrophin releasing hormone for hypothalamus. That kicks in around 2 months before birth and continues almost up to 6 months after birth, and that's known as mini puberty. And if you're missing that, you may, would be expected in Kalman syndrome, for instance, you might well be born with microphallus or cryptorchidism. And when somebody changes your nappies as a little boy, you haven't got morning erections. And then childhood, the axis is quiescent, and then it reawakens during puberty, which can be early, normal, or late. And obviously, if it doesn't wake up, then you may develop you may not develop secondary sex characteristics, you may have unicoid proportions, gynecomastia, small testes. And then later in adult life, if it develops later on, or actually if you're born with it, but nobody ever picked it up, issues relate to reduced libido, low bone mass, low muscle mass, low energy levels, anemia, and infertility. So testosterone secretion varies. It's peaks in the morning, and it's blunted in old age. Almost all of it's synthesized by the testes in response initially to placental HCG, then pituitary LH, very little derived from adrenal precursors, and there's none really stored. It's secreted on demand with a 12-minute plasma half-life. So people through the Brown-Séquard had this idea that if he put subcutaneous explants of monkey testes, then he would rejuvenate himself. But actually, this was just a placebo effect. There's just no stored in the testes, switched on demand. And then testosterone, around 2% of it's free, biologically active. Around 40% is loosely albumin bound, and that's also active. But that proportion that's bound to sex hormone globulin is presumed to be inactive. So in terms of its actions, it's a steroid prohormone. The active hormones are estradiol and dihydrotestosterone. And it has endocrine actions at nanomolar concentrations in the bloodstream, but it has micromolar concentrations within the testis. It has a paracrine action on Sertoli cells to support spermatogenesis. But it's actually predominantly mediated by metabolites estradiol and DHT. Estradiol via aromatase, and 5-alpha-reductase, the two isoenzymes, in reproductive tract, skin, liver, nervous system. And it activates the androgen receptor far more potently and for longer than testosterone. And so some of the actions of testosterone are actually estrogen dependent. Trabecular bone density, closure of epiphyses, fluid retention with excessive testosterone doses. So I know that because that's what the anabolic steroid users do. They inject themselves with so many much androgens, they develop peripheral edema, and so they would use an aromatase inhibitor to try and cut the edema out. They're very crazy. The estrogen-dependent actions are hematopoiesis, myoblast differentiation of muscle, effects on body and scalp hair, external genital development, bone length and cortical thickness, And then combined effects require both effects, libido, spermatogenesis, and feedback inhibition. And we know this from lessons from use of aromatase inhibitors and SERMs like tamoxifen and clomiphene, and also from mouse and human knockouts. So this is the axis here in all its glory. What I would emphasize to you is that the pituitary gonadotroph is really a slave system. There's very little negative feedback happening here. In fact, well, I suppose there's LH and FSH, there's some feedback here. The degeneration neurons here, they're total slaves. They're just literally doing what the arcuate nucleus candida neurons are telling them what to do. But most of the feedback is up here at the arcuate nucleus candida neurons, and the various things like too much fat, sleep apnea, chronic disease, shut down, too little fat, energy deficit, leptin, shuts the axis down. All the negative feedback is happening up here. This just shows the diurnal rhythm, highest in the morning, lowest at night. And this is the effect of an oral glucose load, just really making a big drop in your LH-mediated testosterone secretion. And that occurs both in men with normal glucose tolerance, type 2 diabetes, or even impaired glucose tolerance. And the same effect seen with combined glucose energy drinks or with pure protein shakes. This is the reason why it's always worth getting a second blood sample. Just sometimes you may just catch someone where there's a long gap between the LH pulses, and they may have a very transient low testosterone level. So general principles of lab diagnosis: always measure samples fast before 11 a.m., preferably after a good night's sleep and not during illness. What would support a diagnosis of hypogonadism? So a raised LH is like a game changer. All this agonizing about like a borderline low testosterone level, that only really applies to men who've got like a normal or low normal LH. If your LH is up, you've got hypogonadism. The end. Things like low bone density, anemia, support the diagnosis, or serum testosterone below low limited range on at least 2 separate occasions. So when you're thinking about central hypogonadism, and the LH is thus not raised, the highest serum testosterone trumps all the other results. So you've got a level of 6 or 5 or 3 nanomolar per liter, doesn't matter. If you've got a level of 10, 12, whatever, that's it. All the low ones get cancelled out. They don't count. Further investigation should probably include basal pituitary function tests, particularly prolactin, iron studies, and usually MR scanning, unless there's a really obvious cause. So, someone who's literally doing competitive athletics and has run their total body fat into the ground, I think that's a pretty obvious cause. Someone who's on high dose opiates, I think that's a pretty obvious cause. So there's a problem with our assays in the UK and probably also in Pakistan. So in the USA, there are 3 commercial immunoassays for testosterone. They're all standardized against CDC Atlanta tandem mass spectrometry. But in the UK, there's no standardization. And between the different immunoassays and even the different tandem mass spec units in the UK, there's significant inter and also intra-assay variability. And also tandem mass spec isn't the game changer we thought it was. In the female range, it completely outperforms immunoassays. But in the male range, actually the best immunoassays outperform a lot of the tandem mass specs. And also the other problem is that no matter how much you try and perfect the assay, the normal ranges, the ones the manufacturers provide, we don't know what they're based on. How many men? What was their BMI? Were they fasted? Were they 9 a.m.? These data are not supplied. And so low negative normal in different UK assays varies from between 4.9 to 11. And so this is a project that actually the UK Society for Endocrinology and the Association of Clinical Biochemists are taking on board to try and achieve, first of all, better inter-assay standardization, but also to try and make some sense of the normal ranges. Because having a good assay with a normal range that's built on sand is just not good enough. So some questions you might want to ask your lab. Does your lab use the Beckman assay? It's a disaster. Does it simply quote the manufacturer's reference range, or has it established its own reference range? And how is that range established? Do they stratify according to age? Does your lab participate in national quality control? So this is the free hormone hypothesis, showing the different distribution of testosterone according to binding. And the presumption is that it's only the free or bioavailable that's biologically active. However, you'd love to be able to analyze free testosterone directly, but actually the direct assays are either really laborious and can't be translated into clinical use, or they're rubbish. So you're left with doing the calculation, the mass action equation, feeding SHBG, testosterone, and albumin. And of course, some people, Handelsman in Sydney still doesn't believe it. So what are the things that affect SHBG? So it's high in older age. So the higher the SHBG, the lower your free testosterone. So older age, thrombosis, low BMI, liver disease, HIV, estrogen treatment, anticonvulsants. And it'll be low in men who are younger, hypothyroidism, insulin resistance, hyperinsulinemia, androgen therapy, or androgen abuse. And that's why we saw those two very different body appearances, the bodybuilder and Homer Simpson, who had similar biochemical profile. But we know that when you've got a very high SHBG, total testosterone overestimates androgenicity, and vice versa. So free testosterone calculation would seem to be quite useful. The problem is that the problems I outlined you for testosterone assays in the UK are even worse for sex hormone binding globulin. And sometimes our biochemists say, look, we know what you're trying to do with the mass action equation, but really, we've got you a beautiful testosterone assay, and you're kind of contaminating it by this feeding data from a rubbish SHBG assay. And there's a little bit of ongoing debate between us and our biochemical colleagues. So what we agreed with the biochemists is this, that if your SHBG is mid-range, your calculated free T adds no extra value beyond total testosterone. But it does correlate better with androgenicity, the free testosterone, things like sexual function, bone density, and hematopoiesis, when your SHBG is really at the extremes or beyond the extremes of the reference range. And so these are the times when to measure it. But of course, 7 assays for testosterone in the UK, 6 for SHBG, and we have like limitless permutations of calculations and reference ranges. So it's worth doing when your SHBG is at the extremes of the reference range, because it may help you avoid overdiagnosis or underdiagnosis. But the calculation is not a miraculous thing, and it's certainly not perfect. So, but for all its messiness, the calculated free T correlates better than total T, sexual function, bone density, erythropoiesis, and inversely with LH levels in primary hypogonadism. But the advantage is negligible unless you've got extreme end SHBG levels. Some labs quote what's called the free androgen index, which is simply testosterone divided by SHBG. It's completely useless. But you could also say, well, actually, we're measuring a testosterone level. That's one remove from testosterone action, which is androgenicity. So what you're looking at, we're really measuring one aspect of the process, which is testosterone binding the androgen receptor, and particularly often metabolism to DHT, and it promotes a cascade of processes that result in the clinical features of androgenicity. And the androgen receptor actually encodes a highly polymorphic N-terminal tract, which ranges from 9 to 36 repeats. And essentially, the longer the number of repeats you have, the less active your androgen receptor is. And so what defines androgenicity is how many repeats there are on your androgen receptor, what your serum testosterone levels are, modified by SHBG, and also how much 5-alpha reductase you got, how much dihydrotestosterone are you making. And we just can't calculate that. Just out of interest, the least, shall we say, active receptors are found in North and East Asians, the most active receptors in Africans, and us Caucasians and South Asians, we're somewhere in between. Chronic illness. So as I said, the pattern is indistinguishable from central hypogonadism, except that when you cure that chronic condition, your axis wakes up again and goes back to normal. And it doesn't really matter what the condition is that's been looked at, whether it's like post-MI or burns or whatever, you get the same suppression of the axis. Obesity certainly does it, and we know that if you gain weight, whether the, shall we say, the honest way through weight loss, diet, or bariatric surgery, the cheats way, as you lose the weight, testosterone level will rise. So it's a physiological response, non-gonadal illness. It's just like non-thyroidal illness. We don't know whether it's adaptive, maladaptive, or just neutral. Some people in the type 2 diabetes world believe that it's very maladaptive, and they believe that testosterone has some really useful functions in men with what they call secondary hypogonadism, and I would call non-gonadal illness. But we can drill that into the detail and see what the studies show about in that area later on. If I don't cover that, remind me. But it's interesting that only the male axis is suppressed by obesity. And it also seems to be a bidirectional relationship. So if you induce hypogonadism, say in a man with prostate cancer, with GnRH analog, you will induce obesity insulin resistance. And similarly, if you treat a man with secondary hypogonadism, obesity, or non-gonadal illness, that actually increases lean body mass and insulin sensitivity. However, studies have shown it only protects against type 2 diabetes if you're giving really quite high doses of testosterone, enough to cause high rates of erythrocytosis, and also when combined with active lifestyle interventions. So, male secondary hypogonadism in a diabetes clinic, you would expect to see a lot of this. But the question is this really hypogonadism? You obviously need to screen for prolactinoma, hemochromatosis, and wider hypopituitarism. Consider the possibility of sleep apnea. But really, lifestyle change is the Rolls-Royce treatment that delivers a full range of benefits, including lower blood pressure, improved quality of life, and psychosexual function. So if you give high dose, you will achieve improvements in sexual function, but they're relatively modest. And if combined with lifestyle, you can actually turn back diabetes to non-diabetes, but at the cost of very high rates of erythrocytosis. Testosterone aging and testosterone obesity are actually quite linked, more than we realized. This is one of these slides that has us all terrified, say, oh my goodness, we're all going to be hypogonadal. And there's been a lot of interest thinking about male aging and hypogonadism because they have a lot of things that are in common. But does that mean that treatment for one will be a good treatment for the other? This is where the European male aging study was very useful. In terms of this late onset or obesity-related hypogonadism, they identified 3 key sexual symptoms: low libido, few spontaneous erections, and erectile dysfunction during sex or masturbation. You need to have at least 3 of those, and a serum testosterone below 11 nanomole per liter, and calculated free testosterone under 220 picomole per litre. But the key thing they found was that this so-called age-related hypogonadism, actually, it was all to do with obesity and comorbidities and chronic disease burden. There was no direct relationship to old age. So here is the graph. So we see that top left, we see about 2% of older men as having primary hypogonadism, high LH, low testosterone, easy diagnosis. These men, normal LH, normal testosterone, they're normal, fine, very easy. These men up here, normal testosterone, high LH, are said to have compensated hypogonadism, but that's a biochemical compensation. And actually, if that man's got gynecomastia, or they've got oligospermia, or they've got anemia, or osteoporosis, you think, hang on, just how compensated is that? And actually, if you're a man with normal testosterone and high LH, and you've got gynecomastia, painful gynecomastia, the only effective treatment is testosterone. There's nothing else you can give, apart from surgery. And prevalence of that is around 10% in men over the age of 40. So, and then what they call secondary hypogonadism, all these men down here, but that's a biochemical diagnosis. That's just based on low LH, low T, and that's about 11, 12%. How many of those have actually got symptoms? Much lower, 2.2%. And that's BMI related, not age related. Whereas these two up here with a high LH, that's both age and BMI related, or comorbidity related. So the true age-related hypogonadism is where your LH is up. This is really interesting. If you've got a high LH, whether testosterone is low or normal, your risk of type 2 diabetes is trebled. Whether you've got Klinefelter syndrome, or dystrophy myotonica, or age-related, trebled risk of type 2 diabetes. We don't know if that risk, we don't know the direction of causation, and we don't know if that risk is reduced by testosterone treatment. But clearly it can't be all testosterone, because otherwise the risk would be lower in those men with compensated hypogonadism. I'm not totally sure what's going on there, but expect to find substantially more men with high LH hypogonadism in diabetes clinics than you would in the general population. This is the Chinese equivalent of EMAS. This is SPECT China, which found virtually identical numbers, with one exception actually, and that is that this relationship between testosterone and comorbidities, lowering and age, only applied up to middle age. Older Chinese men in their 70s and 80s, these are the immortals. They'd survived Chairman Mao, Cultural Revolution, mass murder, famine, Communist Party, everything. Stick thin, tough as whipcords, no excess body fat. They maintained the testosterone levels of, and they hadn't adopted Western diets, so they maintained the testosterone levels of younger Chinese men. So this isn't, so apart from those with primary gonadal failure, about 2% in older men, this decline in serum T levels with age, it's not inevitable. And so we know that after the age of 40, the rate of developing primary testicular failure is around 0.2% per year, and increases in tandem with both chronological age and burden of illness. And these are the ones that I prefer to term late onset hypogonadism. And this is, I haven't done ward work for many years now, but this was the last time, one of the last times I did. I was on the wards for a month, and with an excellent registrar, Ahmed Al-Sharefi. And we said, well, we're just going to look and see what our pickup is for primary hypogonadism. Men with anemia. And so about two-thirds, a third of the patients were male. Of those men, about half of them were anemic. Of those men who were anemic, in about half of these, the anemia was unexplained. And in those men with unexplained anemia, half of them had a raised FSH level. We didn't use testosterone as a screening tool because we didn't want to be picking up non-gonadal illness. And of these men with a high FSH, 6 out of 7 had full-on hypogonadism and were started on testosterone. And we found that really, two of them had been in the geriatric run bone clinic on osteoporosis treatment with alendronic acid, although actually alendronic acid has no fracture data in men. Only zolendronic infusions have fracture data in men. And when I talked to the geriatricians, they were saying, oh, look, but there's so many false positives here. These are older men, they're meant to have low T levels. I said, no, you haven't understood this. In fact, this study was prone to false negatives. The study was designed to avoid false positives. We would miss all men with central or secondary hypogonadism. We would miss all men with primary hypogonadism, but who weren't anemic. We would miss men with primary hypogonadism and anemia, but for instance had a low ferritin level, or they suspected GI bleed. Or we would miss men who had primary hypogonadism, but were so ill through their pneumonia or whatever, that actually FSH was suppressed into the normal range. So, where to find hypogonadal men? Sure, men with 3 or more symptoms and sexual dysfunction, adults born with pediatric syndromes, childhood cancer survivors, radiotherapy to brain or testes, alkylating chemotherapy, unpublished data, immune checkpoint inhibitors seem to be doing strange stuff to the testes. Watch this space. They're coming from fertility clinics. Azoospermia. Testicular cancer survivors, particularly the orchidectomized, after skull base and pituitary surgery, radiotherapy. Klinefelters, 1 in 600, males at birth. And I've seen data for Down syndrome, unpublished. Primary hypogonadism, very common, just nobody looks for it. Older men with osteoporosis and fracture. So yeah, men generally do not fracture, or they do not generally have fragility fractures. If you see that, you need to really screen all of them for hypogonadism, anemia and frailty. So this is Down syndrome. Unpublished data from Lausanne, and you can see how the majority are up there in the compensated hypogonadism group. Not many are eugonadal, and a few have got full-on primary testicular insufficiency. The neurologists who look after Down syndrome have no idea. So, what I'm trying to say is that people assume that we're going to be finding hypogonadal men amongst the obese middle-aged men with slightly low libido. And I'm just trying to say that actually you may see them in little neonate boys with macropenis hypogonadism, for instance, or you might see them in very older men with fracture osteoporosis. So I'm going to talk a little bit now about testosterone abuse versus safe prescribing, so abuse or including irresponsible prescribing, some options for testosterone replacement, risk benefits and monitoring, effects on bone health and hematopoiesis, prostate safety, cardiovascular safety. And I'll start with referral received by my fantastic colleague in Newcastle, Yasser Mamouji. GP referral. Falling testosterone levels with hair loss and low mood, poor concentration, lack of libido, 45-year-old man. He feels that life is no longer worth living. Testosterone level 4 done at the surgery. Had it checked privately, 2.27. Could you please see him in clinic as soon as possible? And what Yasser is very good at doing is looking back in, because there are often past results on the system. And we can see that this could be hypogonadotrophic hypogonadism. Could be, but prolactin is normal. We can see that the gamma GT and ALT are raised. Okay, so could he be an obese man with fatty liver? Or could he be someone who's abusing anabolics? Testosterone of itself, native testosterone, does not cause liver anomalies. This is the key figure. Hematocrit 0.528. This guy's taking stuff. And there was some historic radiology on the system. And so we can see, you look at his elbow there, just massive amounts of muscle. Look at that neck, massive amounts of muscle. An elbow x-ray, right upper arm injury sustained during boxing last night. Again, massive biceps. So this guy's just been using anabolics, obviously. And you can get them from everywhere. I'm not sure, have any of you practiced in northern Pakistan, close to the Afghan border? Because actually, bodybuilding anabolics is big in Afghanistan too. And you can get this stuff from anywhere. You can't detect it in serum assays. Although anabolics activate the same androgen receptor, they cause slightly different post-receptor processes. And the pattern of gene transcription favors anabolic versus androgenic actions. There's a much greater risk of cardiotoxicity and hepatotoxicity. You just get them anywhere. But interestingly, even men who say they're not taking androgen anabolics, but I'm taking these bodybuilders' vitamin D supplements or these bodybuilders' creatinine supplements. Half of those, if you put them through tandem mass spec, are adulterated with undeclared anabolics. You just don't know which half. So where the story starts, so testosterone, first isolated 1935. Mr. Olympia bodybuilding starts just after the war. 1965, first use of anabolic steroids in weightlifting championships. You'll recognize the flag of shame. They've always been like cheating sneaks. They were then, they are now. A few years later, International Olympic Committee bans androgens and anabolic steroids and starts drug testing. Bizarrely, in 1977, the American College of Sports Medicine decided that they were ineffective for muscle gains, at which point the abusers said, these doctors are idiots, they know nothing. 81, the first underground steroid handbook. 87, the American College kind of changed their minds. Massive state-sponsored doping program in the former East Germany. Okay, so if you want to tell which countries are the biggest cheats at sport through doping, you look at the relative performance of their men's versus women's teams, because actually you can improve the performance of a female athlete with testosterone more so than that of a male athlete. So if you've got a country that its female teams are winning Olympic medal after Olympic medal, but its male teams are winning so-so, big cheat, big cheat. And in 1999, the World Anti-Doping Agency was established. 2012, Lance Armstrong, the cyclist, was stripped of all his titles. And so we see these are designed to favor protein building over masculinizing. And you can do an anabolic androgenic ratio according to with testosterone standardized as 1. And here are all the things you can do to testosterone to tweak it. But remember, there's not just androgens that are used as performance-enhancing drugs. People use thyroxine, liothyronine, cabergoline, insulin, growth hormone, and tamoxifen, HCG, clomiphene. There is no end to their ingenuity. So in the UK, testosterone is a Class C controlled drug. It's legal for personal use on prescription, but it's illegal to possess it for purposes of selling or supplying. It's estimated that around 2% of men in the UK and 0.2% of women at any point are using or abusing testosterone. And the archetypal picture is someone who's 18 to 30 years old, white ethnicity, full-time employment, above average income, and actually not in a manual profession, but actually a white-collar, office-based. So yeah, testosterone abuse has gone from elite sport through to amateur bodybuilding. Now it's almost aesthetic motivation. I want to be beach body ready for the summer, to have slightly more sculpted muscle. And there's clearly issues with self-esteem and body image. And the users come in various psychological types in terms of what they're trying to get out of using anabolics. Withdrawal's really difficult. because you get sympathetic activation, headaches, tremor, palpitations, nausea, neuropsychiatric issues, intense fear, depression, cravings, your body dysmorphia gets worse, insomnia, and you also develop post-androgen hypogonadism. Your axis shuts down and can remain shut down for a very long time afterwards. And the things that they try and do to get over it, like cycling on and off, pyramiding, escalating doses followed by tapering, blast and cruise, high dose followed by low dose, they think they're so clever, but they can't fool the hypothalamus. And how long does it take to recover gonadal function? Well, it can take up to a year, although certain things like a newly discovered Leydig cell hormone, insulin like factor 3, that may never recover. And so do the users try and mitigate adverse effect, things like shrinkage of testes, azoospermia. They may try a thing called stacking. They'll add in HCG. And of course, HCG, when you drive the Leydig cells hard, they actually push out more estrogen. And so that's why Klinefelter men will often have gynecomastia, because the ratio of estrogen to testosterone increases. And similarly, if you blast the man's Leydig cells with HCG, again, the ratio of estrogen to testosterone increases, they may get gynecomastia. What do these guys do? They may take an anastrozole. They think they're so clever. What do they do for gynecomastia or edema? Yeah, tamoxifen or anastrozole. Erythrocytosis, they may just try and give blood or chuck blood away. And what if the axis remains suppressed long after the androgens have stopped? They may try something called post-cycle therapy, HCG, plus or minus anastrozole or Clomid. Or they may try and bamboozle you into prescribing testosterone for them and get it onto an NHS prescription. And one question is, should we endocrinologists get involved? And I think if there's a formally commissioned service and we have support from specialists in addiction and mental health, I think that would be reasonable. But just for us on our own, without this network of support, I think it's not the time to be involved, except as part of a research protocol. However, even though obviously some of these men might deserve to win the Darwin Prize in terms of like not passing their genes on to the next generation, I think I'm not sure the female partner should be penalized. So if you have a female partner who's nulliparous and is in the mid to late 30s, by the time he's weaned himself off anabolics, she'll be like past childbearing age. And so I would consider treating them with FSH and HCG to get their axis working. In practice, it hasn't happened, but I would consider it. So what are the options for androgen replacement, legitimate androgen replacement? These are the things we're most familiar with: testosterone, enanthate, propionate, sustanon. 100 milligram every 7 to 10 days, or 250 milligram every 2 to 3 weeks. Patients can actually self-inject. Warm the ampule first. Dip it. Hot cup of tea is about right temperature. A blue needle is okay for injecting. But there's quite a lot of variation between peak and trough levels. And this is where the UK and the US have a different way of monitoring. I think they're both effective. So in the UK, we do bloods at the pre-injection trough, just for the injection, and we're looking to get a low normal testosterone level. In the US, they do the blood test at the midpoint between injections, aiming for mid-range. Other things being equal, and I'll come to that. Patients may get symptoms because of fluctuating testosterone levels, and actually, if you're on 250 every 3 weeks, you may have normal range levels for about half to a third of the time, otherwise high or below. The transdermal gels, these are a mainstay in the UK at the moment. What can go wrong? So first of all, you may not apply the gel evenly. You may not give it time to dry completely before you put your clothes on or before you climb to bed with your partner. It's less absorbed well from hairy skin. But also with blood testing, it's important you wait at least 6 hours after application to a blood test. And of course, some of these guys will plaster the testosterone over the venipuncture site so you can get contamination. Other things being equal, aim for a mid-range serum testosterone. and really trying to avoid transference. I'm told these are less successful in tropical climates, as it can take some time much longer to dry in a hot, humid climate. Testosterone under canoate, it's got a much flatter pharmacokinetic profile, but there's some accumulation between injections. And so what you have to be careful with is over a period of time, you may need to extend, you almost certainly need to extend the injection interval. Big volume, 4 mils, warm the ampule first, slow push 1 to 2 minutes blue needle, watch for paroxysmal cough or dyspnea, could be lipid embolism, but actually no one ever actually comes to harm from this. Your first 2 doses 8 to 10 weeks apart, then 12 weeks to the third, and then your first monitoring blood test is only done on the day of your third injection. Look at those bloods and they'll tell you, do we carry on at 12 weeks or do we extend? Most of the time you'll need to extend. Other things being equal, aim for low normal serum T at trough, or if you're in America, aim for mid-range serum T at the midpoint. However, the hemoglobin hematocrit must always trump serum testosterone and patient symptoms. Other things are not always equal. If you keep banging this in every 12 weeks, there's a very high risk of erythrocytosis. So the primary thing you're looking at on testosterone replacement, the most important parameter, is what your full blood count is doing. And it may take 2 to 3 years to achieve a steady state interval, and my longest interval between injections has been nearly 6 months. And this is difficult in general practice because the idea of like a treatment that has a fixed dose but a variable interval, that's not intuitive for general practitioners. And patients may have difficulties booking appointments. In the US, they've got a subcutaneous version of testosterone enantate in a nice pre-filled injection device. And actually, subcutaneous testosterone enantate has a much smoother pharmacokinetic profile than intramuscular. But we don't have that yet in the UK. You can try injecting the standard ampules of testosterone subcutaneously, and this was first published in the Saudi Medical Journal by a bunch of Omanis many years ago. But because the preparation is not designed for subcut use, some patients may experience sterile skin abscesses. So thinking about old age or disability, this is almost a philosophical point. Geriatricians always say to me, oh, but you're not going to give testosterone to a man who's older. I say, yes. My dad was 97 when he started testosterone treatment. He had a high LH, low testosterone. I needed him on his feet and, and caring to look after himself and to look after mother. Well, yeah, he started when he was 97. But the overwhelming majority of older men maintain LH-mediated Leydig cell function lifelong. And so therefore age should be no barrier to testosterone treatment if the diagnosis is correct. And actually older men may stand to gain a great deal in terms of anemia, osteopenia, reduced vitality, and frailty. And as a general point, if you have physical or mental disability, you should not be denied treatments that would otherwise be considered to be standard. So disability should not penalize you in terms of receiving a treatment that works. And again, the geriatricians have, they have this imagination that somehow if we treat older men with testosterone, they're going to burn the nursing home down. It's just fantasy. This was a man with Kalman syndrome actually, and treatment was initiated at age 67 years. He'd spent his entire life undiagnosed. And you see these characteristic diagonal skin wrinkles, which you might see quite commonly in a postmenopausal woman, but are unusual, very unusual in an older man unless they're hypogonadal. So, what about the risks and benefits and optimal monitoring, testosterone replacement? The first thing to worry about is erythrocytosis and the risk of thrombosis. Other thing we can consider is whether you might be exacerbating benign prostatic hypertrophy, or you might potentially unmask an occult prostate cancer. There is no evidence that testosterone treatment at a physiological dose will induce a de novo aggressive prostate cancer. There is no evidence that testosterone treatment at a normal dose will induce personality change, aggression, or hypersexuality. No evidence of inducing liver disease. In terms of prostate safety, we know that androgen deprivation delays disease progression in metastatic prostate cancer for a while. We also know that PSA screening hasn't been shown to reduce deaths from prostate cancer. We also know that being hypogonadal doesn't particularly protect you against having prostate cancer. And that's because the androgen receptors in prostate tissue are fully saturated, even at moderately low testosterone levels. And the Traverse RCT from the USA, $30 million, showed no prostate cancer signal over 3 to 4 years. The Society of Endocrinology guidance that we put out suggests that prostate screening for hypogonadal male on testosterone should be as per the background male population. There is no screening in the UK, therefore nothing for hypogonadal men. In the USA, there is screening, follow that screening program. More important is to know that prostate cancer there's a much higher risk with family history, with age, and African or Caribbean ethnicity. And obviously refer men who develop new urinary symptoms outside testosterone. Why do we worry about cytosis? It really comes from these two population studies, which as far as possible were cleaned up in terms of taking out men with polycythemia vera or chronic lung disease. The Tromsø study and the Copenhagen study, and the Tromsø study showed 50% increased risk of thrombosis and a 240% increased risk for unprovoked thrombosis in men with hematocrit in the top 20 centiles compared to the lowest 40 centiles after adjusting for other factors. And Copenhagen showed that the top 5% for hematocrit had a 50% increased risk of cardiovascular events compared to the middle 50 centiles. And so how do we manage or avoid erythrocytosis in men on testosterone? First thing to say is that there is no role for routine venesection except in JAK2 disease, polycythemia vera. There is no evidence that it will benefit, and there are actually indirect data to suggest that venesection may even promote thrombosis, might be prothrombotic through effects on hypoxia-inducible factor. Your primary management is you just need to lower the overall testosterone dose, and you may even need to interrupt treatment for a while. But there are also some supplementary strategies. Convert from IM testosterone to a gel. Lifestyle, stop smoking, lose weight, identify and treat sleep apnea. A lot of these men, older men, are hypertensive, so avoid using diuretics or drugs which of course cause a reduced plasma volume. You can have a high hematocrit for two reasons. You can have more red cells, or you can have a low plasma volume, or you can have both. And obviously drugs like calcium blockers promote edema, that can then promote getting you on a diuretic. Our experience in Newcastle is that to treat even borderline diastolic hypertension fairly aggressively with a vasodilator, an ACE inhibitor, or an ARB, you vasodilate the blood vessels. What's going to fill that space? Plasma. So that reduces the hematocrit. And take great care in patients on SGLT2 inhibitors, because SGLT2 inhibitors, marvelous drugs as they are, they increase erythropoiesis in a very similar manner to testosterone. And that can be great if you're a patient with chronic kidney disease, but maybe less so if you're a hypogonadal male on testosterone. Bone density. This is a very interesting area. This just shows how you can have a very late diagnosis of congenital hypogonadism, and with testosterone treatment, you can achieve the most astonishing improvements in bone density. And all the studies done on testosterone and bone density, whether they looked at DEXA or QTCT, whether it's classical aerial bone density or volumetric or cortical or bone microarchitecture, they've all shown that testosterone treatment improves all parameters of bone health. And therefore, testosterone treatment really should be the first-line treatment for osteoporosis in organic hypogonadism. We don't have RCTs available. You can't randomize men with Kalman syndrome or Klinefelter syndrome or orchidectomized to placebo. We presume that testosterone treatment will bring their risk of fracture back down to baseline, but for the hypogonadism. However, when the fracture risk is really high, according to our guidance, consider adding a bone-specific agent. But actually, only IV Zol has fracture outcomes in males, and that's only vertebral. But there's a problem in men that I would say have non-gonadal illness, or fat men, older men with cyclic testosterone, or others might call as having functional hypogonadism due to obesity. The Traverse study showed that testosterone treatment was associated with an increased risk of fracture. Problem. Albeit they did no DEXA scans. But hang on, these men don't really have proper hypogonadism. They're overweight. They're probably at low baseline risk of fracture anyway. But what's interesting was the excess fractures were activity-related ones, not fragility fractures. And the risk increased from 3 months of starting testosterone treatment, suggesting that it was a behavioral or bone density independent mechanism for fracture. But it's pause for thought, isn't it? Another reason to think twice before giving testosterone to a man who has a slightly low level in relation to obesity. Testosterone and anemia. This is from the National Gallery in London. Mars, male, that's hemoglobin hematocrit. Actually, no, that's the little childy things. Yeah, that's the kind of child's hemoglobin hematocrit range. That's Venus's, similar to the child's, and that's Mars, higher HbHCT, and it's just testosterone that does that. The mechanisms aren't fully known, but they're very similar to those invoked for SGLT2 inhibitors. They may stimulate directly red cell production in bone marrow. They may cause increased sensitivity to erythropoietin. They may indirectly act via increased renal EPO secretion. They may inhibit hepatic hepcidin secretion. So what hepcidin does is it tells enteric epithelial cells to fall off. They're the cells in which iron is absorbed from the gut, and they can either transfer that iron into the circulation, or the iron can stay locked in the cells. And hepcidin says, iron, stay locked in your cells. And so when they reach the end of the natural lifespan, they're sloughed off into the gut along with all the iron that's not absorbed. And that's the basis of anemia of chronic disease. So we know that testosterone deficiency is associated with low hemoglobin hematocrit, either in hypogonadism, childhood, female sex, and we know that testosterone abuse or overtreatment, here's Lance Armstrong again, can cause erythrocytosis. Of the trials, the first trials, they're called the T trials, a set of 7 interlinked trials in the USA, that really, and these were studies done on, again, fat older men with low testosterone, but with relatively controlled comorbidities. And they found a modest increased improvement in sexual function. These men with secondary hypogonadism or functional non-gonadal illness. And by modest, what I mean is you might be getting like half an extra sexual thought every week. But it was there. These studies showed no improvement in vitality, no improvement in walking, no improvement in perceptions of health and energy. However, trial number 7 looked at men with anemia. And we know that anemia is associated with high mortality in old age, and about a third of older men have anemia. Although interestingly, only 16% of men in the T trials had anemia, which may reflect how hyper-selected these men were to really try and rule out the most egregiously unhealthy. And testosterone treatment eliminated anemia in 60% of cases. whether you thought you knew the cause of anemia or whether you had absolutely no idea. And these men, unlike the generality of men in the T trials, experienced better walking, greater vitality, improved global perceptions of health and energy. And what I wonder is, was their improvement in sexual function also better? I don't know, that hasn't been analysed. Cardiovascular safety. When we published our UK guidance, we had to say the effects on testosterone cardiovascular safety was uncertain, particularly in older men. We now have some new data. We assume that testosterone is totally safe for male hypogonadism in younger men, but we can see testosterone scripts are exploding across the world in men who are mainly obese, 40 to 60, which is probably not very well targeted. And there's enormous variation in prescribing behavior from nihilist to utterly irresponsible. And there were proponents saying, testosterone is going to reduce your risk, or testosterone is going to increase your risk. There are lots of conflicting studies. And you can see why. So it's a direct coronary vasodilator, non-genomic, improves angina, but it also, we know from the T trials, promotes non-calcific coronary atheroma plaques. Bad. It increases muscle mass, reduces fat mass, reduces insulin resistance, reduces diabetes risk, maybe. But also reduces HDL cholesterol, bad. Increases red cell mass, improve exercise capacity, VO2 max, good. But erythrocytosis may predispose to thrombosis, bad. So our guidelines conveyed some uncertainty. And we know from androgen deprivation that actually you can greatly increase insulin resistance. But interestingly, what you tend to lose is subcutaneous fat rather than what you tend to gain is subcutaneous fat rather than gaining visceral fat. It's not quite the same, but perfect marker of metabolic syndrome, although it does increase insulin resistance and metabolic syndrome. But on balance, androgen deprivation seems to be bad for diabetes, coronary heart disease, MI, and sudden death. Big scare, the Tom trial from 2010. These were men selected with not a great quality of life, low testosterone levels, taking away the ones with the most severe illness, but there's a high prevalence of hypertension, obesity, diabetes, dyslipidemia, cardiovascular disease. And they were randomized testosterone gel or placebo. They were intentionally targeted to run a high normal testosterone level, which I thought was quite brave of them. And they had a pretty appreciable rise in testosterone and hematocrit, and their stair climbing was improved, and their leg chest press strength was improved. But by 6 months, there were 23 cardiovascular events compared to only 5 in the placebo group, and so the study is terminated by the safety board. The only problem is that in these days, there was no international definition of what constitutes a MACE, a major adverse coronary event. And some of these events reported in the Tom trial were things like edema or feeling dizzy or faint. And well, what does that mean? So 2 different groups decided to look at things in 2 different ways. Our American colleagues decided to spend $13 million doing the Traverse study, prospective RCT, over 4 years. And what the UK decided to do, an individual patient data meta-analysis, looking at what the existing trials had shown. So unlike a classical meta-analysis, we simply look at the data that's presented in the published paper. IPD, you go back to the initial investigators and say, give us your raw data. Which is what we did, and this was led by my friend and colleague Chana Jayasena from Imperial. And effectively, over a mean period of just under a year, but ranging between 6 months to 2.5 years, there were no effects in terms of deaths, heart attacks, or stroke. But it was 3,000 men, 17 trials, 11 countries. So what's the advantage of IPD, of a conventional analysis? You get independent confirmation data quality. Most adverse events do not appear in published articles. And you could also look at relevant subgroups, older men, smokers, diabetes, Many's basal T levels were equivocal. And so the trial, we looked at, these were RCTs with testosterone treatment. There was no other intervention. The sole intervention, they were older men, serum T in the hypogonadal range. They had to be on treatment for at least 3 months. And primary things we're looking at were all-cause mortality, cardiovascular and cerebrovascular events, but also other things we looked at as well. And of the 35 eligible trials, we managed to get IPD data on 17. So half the studies, they released their raw data to us. What were the obstacles? Pharma lawyers citing data protection, death of chief investigator, dog ate my hard drive, whatever. But still, we got 62% of all possible patients who've ever been randomized to testosterone treatment. And you can see the baseline ill health was pretty severe. But actually, none of these trials had cardiovascular or cerebrovascular primary endpoints. And all-cause mortality, there's no signal, nothing. Heart disease, no signal, nothing, not even a hint. Look at the different kinds of sort of cardiovascular events, nothing, not even a hint. Here we kind of combined those studies in which we had IPD data with those that would not release the individual data. All we had was the aggregate data, and actually the result looked extremely similar. In terms of the physiological markers, as expected, testosterone goes up, cholesterol goes up a little bit, cholesterol goes down a bit, HDL goes down, triglycerides go down, hemoglobin aggregate go up. This is all expected, but blood pressure, nothing. And so with the TESTI study found absolutely no cardiovascular signal from the studies done so far. But of course the follow-up wasn't as long as it might have been. So we having spent for £500,000 on TESTIs, we then got the TRAVERSE study data coming out a year later, which were very similar, except the follow-up was longer, up to 4 years, although actually the median follow-up was closer to 2 years. Similar kind of patient group, similar exclusions. And again, at baseline, quite a high metabolic risk profile. And you see they maintained higher levels of testosterone on treatment compared to the placebo arm. The trial was powered to stop once you'd reached more than 256 major adverse cardiovascular events. And we just see in that no increased risk of testosterone versus placebo. Although a high dropout rate, 60% dropout, both in testosterone and placebo. Maybe that affected the fact that the study was happening during COVID, made the follow-up harder. Maybe people didn't perceive they were getting benefit. So effectively, there's no evidence that testosterone treatment elevates cardiovascular cerebrovascular risk in up to about 2 years of treatment. And actually, there was no effect on glycemia. So you can only reduce the risk of diabetes with testosterone if you're using, as per the T4DM study, high-dose testosterone at risk of erythrocytosis and combined with lifestyle. So I'm getting towards the end now. Thinking about the diagnosis of male hypogonadism, my summary. In the diagnosis or exclusion of male hypogonadism, the highest recorded testosterone level trumps all the others. In the same way that you're thinking about, does someone have a prolactinoma, the lowest recorded prolactin trumps all the others. Men with even borderline low testosterone and raised LH have hypogonadism, full stop, or period, as their American colleagues say. Men with normal LH and FSH, but suggestive clinical features, and 2 consecutive morning fasted levels under 8 nanomole per liter are likely to have hypogonadism, especially if the hematocrit is low or if they have osteoporosis or fracture. Levels 8 to 12, some men may be hypogonadal, some may be eugonadal. And you need to do careful clinical correlation there and assess the presence of symptoms or signs. A serum testosterone greater than 12 is not usually consistent with hypogonadism unless the LH is high. I can't emphasize to you how much the LH is a major diagnostic game changer, as to a lesser extent is the hemoglobin and hematocrit. And really, if you have normal fertility or a high normal hemoglobin hematocrit, these are usually incompatible with the diagnosis of hypogonadism. Priorities in monitoring and targeting testosterone therapy: keep the hemoglobin normal range. Try to keep the men happy in terms of sexual function, but not at the price of a high hematocrit. The anabolic steroid abusers, you'll never make them happy. Don't even try. Serum total testosterone or free, according to SHBG, intramuscular. Other things being equal, aim for low normal levels at trough, or in the USA, aim for mid-range levels at the digital midpoint. Other things being equal. In the gel, aim for mid-range levels 6 to 12 hours post-application, other things being equal. But other things are not always equal, particularly the hematocrit. Look at Benetzi by DEXA. Prostate safety, follow the national guidelines for your general population. In older men with obesity, normal LH and FSH, and slightly low testosterone, what the enthusiasts would call functional hypogonadism, what I would call not proper hypogonadism. We know that treatment with testosterone is safe over 3 to 4 years, but it does increase the risk of non-fragility fracture and also slightly of venous thromboembolism. The improvements in sexual function aren't stunning. Vitality, physical performance, general perception of quality of life, these only improve in men who had anemia at baseline. So just here's some depressing facts on the ground. Reproendo and andrology barely feature in medical school curriculum and postgraduate training curricula. And even our endocrine trainees get little exposure. As Brad Annabelt says, male hypogonadism is ubiquitously underdiagnosed, but is at the same time being overdiagnosed and misdiagnosed. And treatment isn't being adequately targeted at the men who stand to benefit the most. If a man comes to you and their symptom is, I find it hard to build muscle, or my sporting performance is falling away, these are not characteristic symptoms expressed by men with hypogonadism. These are symptoms expressed by men with what I call testosterone-seeking behavior. But actually, certainly across the UK, unregulated men's health clinics are exploding. Generally staffed by general practitioners, they're exploiting untimed blood samples, grey zones and uncertainties in the low limit of normal of assays. And they're really willfully misrepresenting the literature, say, oh, testosterone under 14, therefore you're hypogonadal. So many thanks for listening. And, you know, think about other places where you might find hypogonadal men. We just published in Clinical Endocrinology looking at men in the Newcastle Renal Clinic on hemodialysis. The lower your testosterone level, the more EPO you required. So it may be that a nephrological in Newcastle are flushing away at taxpayers' expense expensive EPO in men who could have been better treated with testosterone. And of course, I'm not a diabetologist, but you know, we know that the SGLT2 inhibitors have got great data even in men without diabetes for renal prevention. And so you could think, well, actually, SGLT2 inhibitor plus testosterone, maybe they wouldn't need EPO at all. Massive money saving. So anyway, many thanks for listening, and just available for any questions. Yeah.
So people who are on opiates and who have been taking opiates for a long period of time, and they typically come with ED, and that is, pretty resistant to anything. So if somebody's been on opiates for a good like 10, 15 years, so what is your experience of managing them? And some of them even have had some early fertility, so you don't know whether they're going to be. So now the fertility has somehow been there, but now after many years, they find that nothing works for them.
So that's a really good question. So when I started medical school, in order to get opiates, you have to be like dying of cancer. Now, I've got a bit of back pain, I'll have a tramadol patch. So these prescriptions are exploding. So interesting, the Australian guidance is really tough. They say, well, there are no studies being done on men with opiate-induced hypogonadism, therefore they shouldn't be treated, which I think is pretty brutal, really. So my experience is that testosterone will improve their symptoms to some extent, but only to some extent. And it'll also improve the hemoglobin, hematocrit, it'll also improve their bone density. But it won't be a cure-all for all their symptoms, because some of their symptoms are due to a direct effect of the opiates themselves. You can't change that. If they want fertility, what are your options? So if there is funding, then giving FSH and HCG treatment should restore fertility in most of them. There are also reasonable data for using either a SERM or an aromatase inhibitor. How would I pick which one? Well, obviously aromatase inhibitors are kind of like bad for bone density. So in a kind of skinny little man on opiates, I'd rather not use an aromatase inhibitor. What are the problems with SERMs? Well, they are probably prothrombotic. So again, in an obese man on opiates, I'd rather not use them. So there are a number of options. I think it's totally reasonable to prescribe them testosterone. It won't be a cure-all for them because the symptoms of opiates will still be there. You can't take that away from them. Fertility can potentially be restored. It would be great to have help from who prescribed that opiate in the first place. Is there any way we can reduce the dose? And what's interesting, the doctors who prescribe opiates have absolutely no idea what
about those who are like, they're abusers, like heroin and all that?
So I find these are the men who just simply don't turn up to clinics. And so I think if I were looking after them in conjunction with a doctor with expertise in opiate abuse, and we have clinics in the UK, then I think it would be reasonable to prescribe some testosterone, but only with the assistance or with the input of a doctor with experience in opiates use and abuse.
So does testosterone work on them?
It works a bit, but not hugely. So it does. It will improve their bone density. It will improve the hemoglobin hematocrit. It will improve their sexual function a bit, but it won't be a cure-all because a lot of the negative effects of opiates are not mediated via testosterone deficiency. That's a really good question. But I wouldn't want to be there in isolation without backup from an expert in addiction.
Sir, I have a question. What are your concerns about giving testosterone to the patients with delayed constitutional puberty? Are there any concerns about that?
Yeah, the concerns are the pediatricians are taking too bloody long. And also, so looking at males and females with, they're adults now, they've got proven hypogonadism. At what age did they first receive clinically meaningful treatment with testosterone? Studies show 18 to 19 years. So can you imagine all your high school years, nothing. And so it's clear there's a problem. The problem seems to be one of like late diagnosis and treatment rather than excessively early diagnosis and treatment. So when the kids come to me from the pediatricians, I'm not seeing kids who've had their growth stunted by early testosterone. I'm seeing, teenagers with segmental disproportion, long lower segments, long end, because they got lower dose or smaller doses. And the psychological morbidity of the adults with hypog is truly shocking. Now, I don't know whether that would have been improved by early testosterone treatment, but I can't believe that, delaying it till age 18, 19 years was like a great idea. So the other thing is that pediatric guidance seems to be written in this fantasy world. They talk about, so first of all, they talk about maintaining the normal tempo of puberty. This kid's 17. That's gone, that's gone. Actually, at 17, these men are already tall, they've got segmental disproportion. They need to go through puberty as soon as bloody possible. And so our protocol in Newcastle is to use Navido. No load dose, just every 4 months. So Navido, 1 gram, 4 months, Navido 1 gram, 4 months, Navido 1 gram, and at the end of the year, they're through puberty. And there are no issues or no problems with that. So yeah, I think the problem is of excess, is that, and also the other thing as well is pediatric guidance, it assumes that every child presenting has got some kind of undifferentiated delayed puberty. But actually the ones with congenital hypog will often have something else which tells you the problem. They'll have had neonatal macropenis, or they've had a history of bilateral cryptorchidism, or they'll have anosmia or clefting or something. There'll often be another signal that tells you this child does not have undifferentiated. They should not go down the wait and see, let the diagnostic declare itself pathway. They should be going down the bloody we'll treat them now pathway. So this little battle I'm having with the pediatricians. The other thing I'm having is also with the pediatric surgeons. So if you've got, obviously most men with cryptorchidism do not have an endocrine cause. But actually, for kids who are born with cryptorchidism micropenis, you can diagnose absolutely, you just do a blood testosterone level. If at 3-4 months of age, the LHCP testosterone is 0, you diagnose hypo, Kalman syndrome, or whatever, at that age, which has 2 benefits. First of all, it means that if you give them FSH and LH, 90% of the testes will come down, avoiding surgery. And then, because you made the diagnosis then, you program them to come back at age 12 for pubertal induction, rather than age 18, 19, 20, 24, 70, whatever. And we've just published in Calendo 3 cases of my career of men who slipped through the pediatric endo cryptorchidism thing, or neonatologist thing. And so they select unilateral cryptorchidism at the point of diagnosis of hypog, around 18 to 20 years. And in all 3 cases, pubertal induction with gonadotrophins brought the testes down. No, they just.
When you get them?
Okay.
Testosterone as well as gonadotrophins?
I would, my very first case, I started him on testosterone because he was already slated for orchidopexy. This is before I knew better. And my urologist colleague said to me, Richard, this guy's on my orchidopexy list in a few months' time. I can do it, but in these kids with congenital hypogonadism, they've got a very, very short somatic cord, which you have to like mobilize. And the testes is like 1 minute, it's tiny. It's so easy to damage that. Can you lengthen his somatic cord and make his testes bigger to make life easier for me? Yeah, sure, Kevin, I'll do that. And actually what happened was, both tests, he had combined, we stopped his testosterone, gave him combined FSH and HCG treatment, and then the testes were down in the scrotum. So subsequent cases, we would just go straight to combined gonadotrophin treatment. HCG alone isn't enough. They need combined FSH and HCG treatment, and that can induce puberty, as well as bringing the testes down.
So same would apply to women, to girls?
No, because
Estrogen alone will...
because girls are special. When you think about it, so for a man to develop sperm, he needs to go through 3 phases of particular maturation. So first of all, there's HCG-driven testosterone from 7 weeks, and then there's mini puberty from 2 months before birth to sort of 5 months after birth, and then there's puberty. Whereas girls, in utero, they already have their full supply of ready to go oocytes, good to go. And you could take I don't think it's been done in girls, but it's done in macaques, but you could take a hypogonadal girl with central hypogonadism who hadn't been through puberty and put her on a GnRH pump and ovulate almost instantly. Obviously, she wouldn't have a fully developed uterus. It's not a great idea, but there seems to be no the kind of programming of reproduction seems to be really important for males, but not for females in early life. So the longitudinal study of mini puberty from the Copenhagen group and Azul showed that the highest testosterone, your testosterone level in mini puberty, the highest level, correlates with your sperm count at 20 years of age. There was a study from man in the 1990s taking male macaques. So if you destroy their mini puberty with GnRH analog, just so they don't get that postnatal surge in LH gonadotrophins, and then you follow them to post-puberty, although they do go through puberty and their testes do enlarge and they do develop sperm, the testes volume and the sperm counts are significantly smaller. So if you missed out on mini puberty, that has a long-term effect on your fertility potential.
So if in these boys, so we're talking about boys now. So in these boys who have missed the mini puberty, hypogonadism not diagnosed at birth,
Yes.
and they come to present to you at, let's say, 11 years or 12 years.
Yes.
And if at that time, would you first give them a high dose of FSH for some time to mimic the mini puberty before you start the gradually escalating doses of the low dose?
So if they were cryptorchid, not many of those come through. I would go straight in with FSH, then HCG. Otherwise, I think I would just take them through puberty with, I would give them a choice. And their parents a choice, because it's quite a commitment to have gonadotrophin injections 3 times a week for 2 types of injection. And I'd much rather someone went through puberty with testosterone than someone was supplied with FSH and HCG and squirted it down the toilet. So it partly depends on the commitment of the patient, of the child and their parents, and also whether there's funding available, whether they can afford it. But certainly, one of my pediatric colleagues in London, Sasha Howard, has funding for a gonadotrophin program, and so I regularly get inquiries from parents saying, not my patients, all over the country, saying, I've got a boy who's just been diagnosed with hypog or absent puberty. We're interested in having gonadotrophin treatment rather than testosterone, I say, well, go to Sasha Howard in Barts in London. But she's going to do an RCT of various different
But if you
regimens.
just give them testosterone, would their testes grow?
No.
But they want the testes to grow.
If the testes grow on testosterone, that would suggest they constitutional delay.
Yeah.
But if they want the testes to grow, only FSH and HCG will do that. Yes.
One last question, because
Okay.
I've over asked many my share of questions. So, if, for instance, a boy comes to you at the age of 18 who's missed the, who wasn't diagnosed, and we have a lot of those people who come to
Yes.
us at that age with IHH. I think that's
Yes.
the time when they finally say the puberty is delayed 2 to something.
It's no better in Europe. It's no better in Europe. Although in Europe, it's not always because they weren't noticed. It's because they were given false reassurance.
Yeah.
Oh, you're a late bloomer. Go away and come back again.
It
Yeah.
happens all the time. So in this case, now you want to, if the child comes to us at 11, 12 years, so we basically give them, 2.5 years,
Yes.
slow escalation. But if the same child comes to you at the age of 18, he's still short, he hasn't really grown. So what would you do? Would you give them a slow escalation, or would you like to?
Oh, age 18, libido, bang, 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 take through fast.
How long?
So for over 17s with height preserved, I would give them libido every 4 months.
But if you want your testes also to grow, you have them spermatogenesis.
Well, then they would need to have. So over 18, you see, in the UK, there's no funding for gonadotrophins unless you're actively wanting fertility.
Then what will happen? How do you cope with that?
Well, they have testosterone. There is no funding for so I prescribe gonadotrophins off the budget of Newcastle Fertility Centre. If they found out I was prescribing it to like 20-year-olds who weren't even in a relationship, never had sex, they would go bananas. You're blowing our budget. But it's. Yeah.
My question I want to ask, how do you diagnose hypogonadism at the age of 12 or 13? Because you can't differentiate whether it's constitutional, whether it's obesity, whether the puberty hasn't kick-started, and you just have to wait. So,
Well, you can if they had a history of bilateral cryptorchidism
no, if there's no cryptocode.
or a history of micro, but often there is, 60% of the hypogs have got something which will tell you there's a problem, either in terms of the reproductive features, cryptorchidism, micropenis, or non-reproductive, so cleft palate, cleft lip, deafness, synkinesia or anosmia. A lot of them will have something to tell you.
Okay, so you have to look for these things in the history to be able to diagnose it at an early stage when it's
Yes.
10, 12, 13, 14 years, where you can't be sure whether it's central or it's just delayed puberty.
Well, I think so a couple of things. So in the long term, genetics will become more available. So I'm sure that in 5 years' time, you just be doing a gene panel.
Okay.
But otherwise, certain things differentiate self-limited delayed puberty and hypog. So the hypogs tend to have their linear growth preserved. And so it's a purely a delay in puberty. It's not a delay in growth. Whereas the self-limited delay tends to be in both growth and puberty. So the growth pattern gives you an idea. But also, if you treat a boy with self-limited delay with testosterone, there's no harm done.
Okay.
You can always stop it after a while when you see the testes growing.
And what about an adult man who is obese, overweight, insulin resistant, comes to you with the complaint of gynecomastia, and you do his total testosterone, it's borderline, you do his free testosterone, like you said, some of them are sham, and then his LH, FSH are not raised.
Okay.
So he's got gynecomastia and he's got no other problems apart from that.
Usually these men will have non-painful gynecomastia.
Yes.
You're not,
Yes.
So testosterone's not going to help that.
Okay.
Testosterone will only help if you got testosterone or anastrozole. or will only help if you've got painful gynecomastia.
So then we leave them be, ask them to lose weight. It's just because of their obesity, or
Yeah. So we know what the data are in this kind of man. If you with testosterone, there will be no improvement in diabetes risk unless you're giving megadose associated with lifestyle. There will be a slight improvement in sexual function, but not massive. There will be an increased risk of non-fragility fracture, and things like vitality, physical performance, and perception of well-being will only improve if they had anemia at baseline. So in these kind of men, having anemia at baseline is the game. So my first game changer is at LH. My second game changer, the second order, is are they anemic at baseline?
okay, so you treat them if they're anemic at baseline, otherwise you let them be?
Generally, yes. I tell them that lifestyle weight loss is the Rolls-Royce treatment.
Okay, okay.
How about some men who come to you with what's low normal testosterone, and they have erectile dysfunction, and the low normal is like so it depends. It's around 350.
Yeah.
Would you treat them?
In American units? 350, I would say. That's okay in American units.
Yeah, but they say, I want testosterone.
Yeah, that's testosterone.
It's low.
behavior.
It's 380.
That's testosterone-seeking behavior, yeah.
Yeah.
I just say, right now, with that level of testosterone, normal LH, got normal testicular size, normal hemoglobin hematocrit, do you want me to make you infertile? Because that's what this is going to do. Because whilst I'm boosting your levels of testosterone in the circulation, I'm actually crashing your levels in the testes. Do you want your testes to shrink?
But
And
there
and
is an erectile dysfunction as clinical symptom there.
So we would say in someone such as yourself, the chance of testosterone improving your sexual function long term is exceptionally low. So in someone with normal range testosterone, I mean, there may be a placebo effect initially, but there are no data to suggest that someone with that normal range testosterone level and normal LH is going to experience sustained improvement in sexual function with testosterone. But their balls will shrink and they will lose whatever fertility that they had. But they may still want it, and they'll find someone else to prescribe it.
Or they might off the market in Pakistan.
Sorry?
Or they might off the market.
Yeah. But then if you end up treating them, then they'll want more and more and more because it's not working. I need some more, and then they'll develop erythrocytosis, and can you venasect me now? And you just enter it's the kind of patient you want off your books, really.
The oncology patient can present with the hypogonadism. We saw a lot of patients of Burgard's lymphoma, young age, 25, 26, with delayed a bit secondary sexual characters. So in such patients, the treated case of Burkitt lymphoma, the approach of the testosterone replacement in such patient by chemically proved low testosterone, clinically significant delayed secondary sexual character in form of the decreased testicular volume. On the side, we can say the testicular volume is round about 10 to 12 ml. Along with that, the regression of the axillary and pubic hair. In such patient, how is your approach?
My approach is to try and reprogram the oncologists. Why aren't you referring these? The moment you get an LH climb, patient under endocrine follow-up. When you first, you give them some testis toxic chemotherapy, alkaline agents, and the FSH has gone up. Put them onto us for follow-up because almost certainly they bank sperm as soon as possible. Put them under endocrine follow-up because once the male axis begins to fail, generally the only way is down. And then once your FSH is really high, they'll be totally infertile. And so we would say bank sperm if you can, and then start testosterone early. We think the oncologists are referring patients too late. And there are lots of patients that are even, and a sensitive marker, really sensitive marker, is the FSH level. That's the first marker that you've damaged the testis. And these are the patients that they should say, pass to the professionals to follow up, rather than waiting for them to be fully hypogonadal. Girls are a bit different because the ovaries can develop a premature ovarian insufficiency type picture, and then the ovaries can then recover from after cytotoxic chemo. Of course, maybe they'll then go on to have an early menopause than they would have done because of reduced ovarian reserve. But the girls, yes, the fact that they go into POI phase doesn't mean that they're not going to come out of it. Whereas the men, once the FSH is up, that's something that's just going to keep going higher.
Let's go back to that girl with, thank you, the girl with the delayed puberty and who comes again at 18, 19 years of age with primary amenorrhea and no secondary sexual characteristics. So no breasts, nothing. So when you get to them here, often they're in your clinic because a marriage has been arranged. And they want her to be fertile. So at that point, is it, I mean, of course, you'll give her estrogen first, followed by once she's got the breast development. But then at what point do you give the gonadotropin?
So with the female puberty, you can't hurry that, no matter how old the woman is, in the same way you can do with men on testosterone. Because if you ram too much estrogen into them too quickly, they won't get the best possible breast development. And so that's why we start off with low dose of estrogen and then build up gradually. However, the pediatricians, do give silly doses. So they look at their protocols for inducing puberty in a 13-year-old girl, and they'll apply it to a 17-year-old. You take a 25 microgram patch and you cut it into 16 segments. Oh, come on, they're ridiculous. So if someone's, 17, maybe you might start with half a 25 microgram patch, but you're going to bump the dose up every 4 months. And once they get to 50 microgram patch, you can then begin to measure an estradiol level as well. And what we recommend is that as well as looking at the breast development, that you look at the uterine development. And again, the PEED guidelines are unfortunate because they say, oh, well, start a progesterone if there's bleeding or spotting, indicate endometrial hyperplasia, or just randomly after 18 months, 2 years. Because, these girls, none of these girls are going to die of endometrial cancer. And so what our protocol in Newcastle is, don't even think about introducing progestogen until you're on a decent dose of estrogen, like minimum 75 microgram patch or 2 milligrams oral, and the uterus has stopped growing. When the breasts are TANA 4-5 and the uterus has stopped growing, then you can introduce the progestogen. And you don't, because you're doing the ultrasound scan every 6 months or so, the girls aren't going to get this unexpected bleed because you'll know where it's coming from. So we know from there was this, again, this is just impressive clinical endocrinology. The UCL group showed that their uterine volumes in hypog girls were about 30% smaller than in matched controls. But they were inducing puberty, first of all, with ethanol estradiol, which is an anabolic, not really fully proper estrogen. And they were banging progesterone after 12 to 18 months. And in Newcastle, we're seeing uterine volumes that are just the same as that of matched controls. Because, of course, you want to get a good uterus before you get someone pregnant. So, yes, we would say, at the point where the girl would be ready to start, the woman would be ready to start combined estrogen progesterone cyclical HRT, because the uterus and the breasts are mature, well, at that point, she could have ovulation induction, assuming that she's got hypog. But of course, the fertility clinics, they don't want to do ovulation induction because you can't charge much for that. They'll want to try and flog them IVF because there's more money in that. So it's a little bit difficult. You need to work out which of the gynecologists you can trust to offer ovulation induction gonadotrophins as first line, and he won't just try and bundle them down the IVF pathway quickly. But it's nice if they can conceive naturally, isn't it? And provided over the course of, provided you know, first cycle not successful, go to another cycle, the cumulative fertility rates for hypog women on ovulation induction are similar to those of like a normal woman having normal intercourse, 80% pregnant at 2 years. Gynecologists, they're a problem everywhere.
Our problem is the availability of patches. We do not have the patches. Do we get patches? So some of our patients get patches from abroad, but in Pakistan you don't have it. So then we use.
So estradiol valerate. So what's the lowest dose that you have? Yeah, so that's how. So the lowest dose that we have is 1 milligram, and I guess you can get as far as you can with a tablet cutter. Yeah, we have to say just ignore that. You just have to. But what? So in a 17-year-old, what would be a reasonable starting dose of estradiol valerate? In an ideal world, you start her on 0.5 milligram. In an ideal world, if you could like cut it, cut, or maybe 1 milligram alternate days. Well, in an ideal world, but you know, you don't have to give it every day, you know, and you're trying to. You could probably get away with if the girl simply can't. I'd be reluctant to put someone straight on 1 milligram every day from the beginning, just to try and get the best. But you know, remember, these are all concerns that we inherited from our pediatric endocrinology grandfathers or grandmothers who told us what disastrous high dose estrogen was for breasts. But actually, I think the big problem, much bigger, is when they're stuck straight on the combined pill. So once you're on the combined pill, that's it. Your breasts are stuffed. That you will never. Well, bad luck. You will never get beyond Tanner 3. So that's it. The damage has been done. There's nothing else you can do. Yeah. That's it. The other thing as well is the other problem is the psychiatrists, because they often see the girls with anorexia nervosa, and they believe that the girls should just have behavioral treatment. So what? So they'll leave these girls, and you know, throughout the adolescence with like 0 estradiol levels, during which their uterus won't develop adequately, they won't get full bone density. In fact, they won't even get adequate size of the vertebrae. The vertebrae will have a permanently narrow AP diameter, and they have this ideological belief that hormones are get in the way of our psychotherapy, but really that you just need to bulldoze them. And just say, you stick to the head shrinking, we'll do the hormones, thank you. And to induce puberty as you would do, treat them as if they were an honorary hypog, with incremental doses of estrogen to.
Thank you. I feel like taking a scuba dive into the world of hypogonadism. So just a quick, how does the thromboembolism and cardiovascular risk compare between hypogonadal men receiving testosterone and people who were undergone a gender reassignment?
But for the transgender men, provided that they behave and don't take excessive doses, we think their risk is not much greater than that of hypogonadal men, but we don't know. They do have an increased risk of thrombosis events, but a lot of them are being naughty and taking excessive doses, and refusing to listen to what we say about when their hematocrit's up. And again, what hematocrit to aim at in them? Conventionally we say, well, actually we should aim for a male range hematocrit. But I do wonder about what's a biologically female vascular system. Certainly, I would say, don't ever let the hematocrit in the trans men blip above 0.5. Yeah, that's a very interesting question. But interestingly, there's a lot of transferable skills between, if you're looking after hypogonadal patients and those who are transgender. So, for instance, we sometimes get GPs writing in saying, "Oh, I've got this transgender person, and I've no idea how to look after them. And will you advise?" And you say, "Well, have they been gonadectomized?" You go, "Yes." Right. So actually, they're gonadectomized. They're hypogonadal. In a sense, they're no longer transgender. It doesn't matter what they were in the past. So, this is it, right, okay. It's what they are now. Yasser taught me, there's a thing from Haditha? Yeah, did he say that? Okay, so, a grape. Is a grape okay to eat? Yep, okay, grape's okay to eat. That grape is then, whatever you do, you make wine out of the grape. Is that okay? Wine? No, right? So it doesn't matter what it was originally, it's been transformed. That wine, you then turn it into vinegar. It's okay, because it's vinegar, it's no longer wine. And so I said the same thing, you were once transgender, you've now been gonadectomized. Me, I don't care what it was, you need some sex hormones. And to get across that actually, now treat them as if they were hypogonadal, and what they were once no longer matters. So the trans females tend to be obviously a bit bigger than and obviously older than a young hypogonadal girl, and so a starting dose for a trans female would be around 1 milligram of oral. Yes, and so this is interesting because in the UK, the transgender guidance said, so what happens in the UK at the moment? If you're a hypogonadal man on testosterone treatment, your levels monitored, your treatment adjusted accordingly. It's personalized for you. If you're a transgender man on testosterone, your levels are measured, your treatment's adjusted, personalized for you, levels adjusted. If you're a transgender female, your estrogen levels are measured, your treatment's adjusted, personalized accordingly. If you're a hypogonadal female, take this pill and get lost. So that's what seems to happen. In the UK guidance group for female hypogonadism that got published earlier this year, we and the gynecologists came from totally different directions. They were saying, you should never measure an estradiol level. Well, why not? Well, because we've never done it. You should never measure it because the surgeons, they already know the revealed truth. It's been revealed to them. They know. And the endocrinologist was saying, hang on, you've got someone who might be in treatment for like 40 years on a hormone, and you're never going to measure that hormone level. And we know how variable absorption is. And so the best we could force them into was to say that there is no evidence against measuring hormone levels compared with measuring hormone levels. But you can if you want to. And if you wanted to, what would be a sensible level to measure for estradiol? And luckily, there's a choice of two, and they're virtually the same. So one is the level that's used in UK transgender guidance, 300 to 600 picomole per liter. The other is the level suggested from the recent international Turner guidance, which is 350 to 500. So they almost kind of coincide. So that's what, so I will measure hormone levels in a hypogonadal cis woman on estrogen, as well as in a transgender woman, even though it's only mandated for the trans women. Cis women are meant to be, well, just take this tablet and get lost. It's ridiculous. Aiming for that range, 300 to 600, 350 to 500, there's not much difference. And the thing is, though, what that means is that you won't achieve those levels with standard dose HRT in about half your young women. Or if the highest HRT dose for a combined preparation contains 2 milligrams of estradiol plus a progesterone, that will achieve a level above 300 in half your hypogonadal women. The other half, if you're treating to target, you'll need to add in more estradiol. So maybe 3 milligrams estradiol, 4 milligrams estradiol. And, well, how much progesterone do you need? Should you adjust the progesterone according to how much estrogen you give? We simply don't know. But I guess if someone's having a regular cycle, that indicates their endometrial protection. And also, I'm a big fan of the Mirena coil. I mean, I tease gynecologists, really, I'm jealous because I can't put in Mirena coils. They are just brilliant because they're good for endometrial protection, they're good for menorrhagia, they're good for contraception, and they're a great form of HRT. And sometimes, young girls, even with Turner syndrome, that doesn't matter what preparation we give them, they get terrible bleeding. They just can't cope. And so about once a year, we'll put them on the general anesthetic list for a Mirena coil, just because otherwise bleeding so distressing for them. But yeah. So yes, so if you're going to measure estrogen level, which I think is a good idea, you will end up using higher than 2 milligrams in about half your hypogonadal women. The other thing is, if you've got a young woman and her bone density is not great, and she's on alendronic acid, something's gone badly wrong. You will improve that. But estrogen's got fracture prevention data in women. We know it prevents fracture as well as it doesn't just increase BMD. So it's a safe and effective, and it's the only sensible treatment probably for a woman under the age of 60, really. Because you think bisphosphonate, you use them for 5 years, then it's over. They're not licensed in reproductive age. You finish bisphosphonates, then you've got denosumab. Well, denosumab, you've got 10 years of that. But then if you stop, your bone density collapses to worse than it would have been before you'd even started in the first place. So the more you can push these bone agents down the line, kick the can down the road, is the better for the future.
Thank you very much, sir, for the very excellent presentation and also a wonderful discussion regarding the hypogonadism. I am very much thankful to all of you for active listening and I have active communication. So it's the time for the break now. Thank you very much once again, ma'am. Thank you once again.